If you are a trauma surgeon, you might think, a wound from an M4 military assault rifle is basically the absolute worst thing you could ever possibly see on your operating table.
Right. I mean, it's a weapon explicitly designed for combat.
Exactly.
Yeah.
But according to the actual laws of physics, and surprisingly, a 125-year-old international war treaty, a civilian deer hunting accident is actually engineered to cause, well, far more catastrophic tissue destruction.
It totally defies common assumptions.
It really does.
You hear that phrase, military grade, and you immediately just brace yourself for the worst possible wound profile.
Yeah, you assume the absolute worst.
Yeah, but when you actually break down the ballistics, a standard civilian hunting rifle round is specifically, deliberately engineered to cause maximum internal cavitation.
Well, the military round isn't.
Right. Conventional military ammunition is legally required to minimize that cavitation.
And that incredibly counterintuitive paradox is exactly why we are doing this deep dive today.
It's such a vital topic.
We are pulling from two phenomenal, highly detailed sources to help you bridge the gap between the complex physics of a bullet's flight and the stark clinical reality of your surgical management.
Yeah, taking it from the lab to the trauma bay.
First, we have a definitive clinical chapter on wound ballistics by Philbert Van and Laszlo Kirli.
Excellent text.
And second, an instructional brochure and video curriculum developed by the International Committee of the Red Cross, the ICRC.
Which is tailored specifically for health, legal, and forensic professionals.
Right. And for you, the listener, whether you're an attending trauma surgeon, a surgical critical care fellow, or just a really highly curious medical learner, understanding the mechanics behind that violent energy transfer is, well, it's what separates a merely adequate surgical outcome from a truly life-saving one.
Because when you are scrubbing in, you aren't just operating on damaged anatomy.
No.
You are operating on the chaotic aftermath of a ballistic event.
And we have to acknowledge right up front, this isn't some, rare zebra of a case that you might only see once during a fellowship.
Not at all.
This is your daily reality. Let's just look at the sheer statistical volume of this issue.
The numbers are staggering.
In 2017 alone, firearm injuries claimed nearly 40,000 lives in the United States.
Yeah.
To be exact, that's 39,733 people.
Wow.
That accounted for 16.4% of all injury deaths in the entire country.
And the breakdown of those numbers, it really dictates what you're going to see rolling through the ambulance bay.
Right, because the context of the shooting matters.
Exactly. 60% of those were suicides and 36.6% were homicides.
Which means the trajectory, the range, and the intent behind these injuries vary wildly.
But the bottom line remains exactly the same.
Yeah.
Whether you are practicing in a massive level I trauma center in some dense urban environment, or, you are at a critical access hospital out in a rural hunting community, you will encounter these wounds.
It is an absolute certainty in your career.
100%.
Okay, so let's unpack this. We need to move from the raw statistics of mortality into the actual science of ballistics.
The physics.
Right. What is actually happening in that microsecond a projectile strikes human tissue? I want to move past this simple idea of just, a bullet punching a hole.
To move past the hole, we really have to start with the fundamental equation of physics that governs this entire discipline.
Okay, take us back to physics class.
Kinetic energy equals 1/2 times mass times velocity squared.
E equals mv squared over 2.
Exactly. If you keep that single equation in your head, the seemingly random destruction you see in the trauma bay suddenly starts to make, perfect mathematical sense.
So E equals 1/2 mass times velocity squared. Mass and velocity are the two variables we're dealing with here.
Right.
But looking at that formula, they are definitely not weighted equally.
Not at all. And that is the most critical realization for a trauma surgeon.
Because of the squared variable.
Because the velocity variable is squared, yeah. An increase in a bullet speed is vastly more destructive than a proportional increase in its mass.
Can you give an example of how that scales?
Sure. Let's say you take a bullet and you double its weight, its mass.
Okay.
You have just doubled the kinetic energy it carries.
Simple enough.
But if you take that same original bullet and you simply double its speed,
you quadruple its kinetic energy.
You quadruple it. Velocity is the absolute dictator of tissue destruction.
So how does a weapon actually generate that velocity? The text talks about muzzle velocity. The speed of the bullet, the exact moment it leaves the barrel.
Right. Muzzle velocity is determined by a few tightly controlled factors in the weapon's design.
Like what?
It depends on the diameter of the bullet, the specific amount of gunpowder packed into the brass casing, and the length of the weapon's barrel.
So when you pull the trigger,
When the firing pin strikes the primer, the gunpowder ignites, creating these rapidly expanding gases.
right.
Those gases act like a high-pressure piston, basically forcing the bullet to accelerate down the length of the barrel.
So longer the barrel, the more speed you get.
Exactly. The longer the barrel, the more time those gases have to push and accelerate the projectile before it finally exits.
And once it exits, it's immediately fighting a losing battle against air resistance, gradually slowing down.
Yeah, physics takes over immediately.
But eventually, it strikes a target. The sources are very clear that when that bullet hits a human body, we are no longer just looking at a single path of destruction.
No, it's much more complex than that.
There are two entirely distinct interactions occurring simultaneously, right? The permanent cavity and the temporary cavity.
Yes, let's define the permanent cavity first, because it's the easiest one to conceptualize.
It's the hole.
It's the hole. When you are exploring a wound track in the OR, the permanent cavity is the obvious path of tissue destruction. It is the direct, physical crush injury.
As the metal pushes through.
Right. As that rapidly traveling metal forces its way through, it directly crushes, tears, and lacerates the cells, the vessels, and the organs in its immediate physical path.
It is the literal hole left behind.
Exactly.
Right, so that's the injury that makes intuitive sense. You see a whole, tissue is destroyed there.
Sure.
But the temporary cavity is where the hidden, insidious danger lies.
That's the part that catches surgeons off guard.
As that bullet forces its way through the dense medium of the human body, it doesn't just cut a path, it causes a violent lateral displacement of adjacent tissues.
It shoves the tissue violently outward, away from the bullet's path.
The sources use a really good analogy for this, don't they?
Yeah, think of a snurry plow moving down a highway at 80 miles an hour.
Okay.
It isn't just clearing the lane it occupies.
No, it's throwing snow everywhere.
It is violently throwing snow across 3 other lanes. In the human body, this temporary cavity, this immense shockwave, can affect an area many, many times greater than the actual diameter of the bullet itself.
Wow.
It expands radially, stretching and tearing tissue that the bullet never even physically touched.
And this is where the surgical challenge truly begins, because the clinical importance of that temporary cavity depends almost entirely on the specific anatomical site of the injury.
And the inherent elasticity of the tissue involved.
I'd love to break that down. How does tissue elasticity fundamentally change what you see on the table?
Well, let's compare 2 completely different organs, say the lungs and the liver.
Okay, polar opposites.
Exactly. Lung tissue is highly elastic. It is spongy, compressible, and designed to expand and contract.
But it is also incredibly vascular.
Very vascular. So if a high-velocity bullet passes through the chest and creates a massive temporary cavity, that rapid, violent displacement of tissue stretches the spongy lung outward.
Does it tear?
Well, the lung tissue itself might actually survive the stretch, but the microscopic capillaries and alveoli within it are absolutely shredded by the pressure wave.
Resulting in a severe pulmonary contusion.
Right.
The chest x-ray will show a massive whiteout of bleeding and edema, even if the bullet itself missed the major pulmonary vessels. You are essentially treating the shock wave.
Precisely. You're treating the blunt force trauma of the blast wave inside the chest.
Now, contrast that highly elastic lung with the liver.
Right. The liver is a dense, solid, relatively inelastic organ.
And cannot stretch.
It cannot stretch at all. So
right.
when a high-velocity shock wave expands inside the liver, the tissue doesn't stretch and bounce back.
What happens?
It simply shatters.
Oh, wow.
The temporary cavity causes massive, deep fracturing of the hepatic parenchyma, leading to catastrophic hemorrhage far beyond the actual permanent wound track.
So the viscoelastic properties of the organ dictate its survivability.
Well, 100%.
But the size and violence of that shockwave, that temporary cavity, isn't just a static number based on the gun.
No, not at all.
It depends heavily on how the bullet is actually behaving in flight before it even breaks the skin. The texts go into fascinating detail about bullet stability and aerodynamics.
Yeah, so inside the barrel of almost every modern gun, there are spiral grooves machined into the metal. This is called rifling.
Like a football spiral.
Exactly. When the bullet is forced down the barrel, This rifling grips the metal of the bullet and forces it to spin around its long axis.
How fast are we talking?
Sometimes anywhere from 1,500 to 6,000 revolutions per second.
That is an unimaginable rate of spin.
It really is. And the entire purpose of that spin is to give the bullet gyroscopic stability in flight.
To keep it flying straight.
Right. It keeps the bullet pointing forward rather than tumbling end over end through the air, which would ruin its accuracy and its speed.
Okay, I want to use an analogy here to really visualize this. If I'm an NFL quarterback and I throw a perfectly tight spiral, that football is cutting through the air aerodynamically. It's stable.
Sure.
What happens when a bullet, flying in a perfect tight spiral, suddenly hits human tissue?
It's a great analogy, but we actually have to add a layer of aerodynamic reality to it first.
Okay, lay it on me.
Even with a tight spiral, a bullet's flight is never perfectly straight. The texts mention two specific aerodynamic forces: precession and nutation.
Meaning a wobble.
Yes. Even as it spins, the very tip of the bullet is making tiny microscopic circles as it flies. It is wobbling slightly around its center of gravity.
Does it do that the whole time it's flying?
Well, for the first meter or so out of the weapon's barrel, the bullet is incredibly stable. Then it goes through a brief phase of lower stability where that wobble, the angle of precession, actually increases.
And then,
As it travels further downrange, it settles down and regains its tight stability.
so, depending on the exact distance between the shooter and the patient, that bullet might be flying perfectly straight or might be in a phase of slight wobbling.
Exactly.
How does that wobble translate to the chaotic tissue damage we see in the trauma bay?
This is the absolute crux of wound ballistics. If a stable, non-extending bullet hits tissue, it initially creates a narrow, straight track.
Because it's aerodynamic.
Because it is penetrating tip first, its surface area, the part actually pushing against the tissue, is very small. It's aerodynamic. Because the surface area is small, it isn't depositing its kinetic energy very quickly. It's just slicing through.
But human tissue is roughly 800 times denser than air. That perfectly thrown football is suddenly hitting a wall of water.
And that dense medium immediately strips away the bullet's gyroscopic stability. The center of aerodynamic pressure overwhelms the center of gravity. The bullet begins to yaw.
Yaw meaning the nose dips and the bullet turns sideways.
Yes, it begins to tumble. And think about the surface area of a bullet.
Right.
The tip is tiny, but the side profile, it's huge.
Oh, I see.
When a bullet turns sideways, its surface area hitting the tissue increases massively. It goes from being an aerodynamic needle to being a blunt brick.
And that sudden stop.
The area of contact determines the rate at which energy is transferred. So the exact millisecond it yaws and turns sideways, it suddenly dumps a massive, catastrophic amount of its kinetic energy into the tissue all at once.
And that energy has nowhere to go but out into the tissue.
Right. The temporary cavity balloons outward at that exact specific point in the wound track where the bullet yawed. That is where the shock wave is generated.
Which perfectly explains a clinical phenomenon that can be, deeply confusing for a junior surgeon.
The range paradox.
Yeah. A bullet wound sustained at a long range, say 300 yards, might actually show less internal tissue damage than one sustained at close range, even from the exact same weapon.
Right, because at long range, the velocity is lower, which means less kinetic energy overall.
But more importantly, the bullet may have regained its perfect flight stability.
Exactly, meaning it might just pass straight through the limb without yawing as violently.
So the yaw is what dictates the energy dump.
Yaw is everything.
And knowing that this energy transfer is the absolute dictator of tissue destruction naturally leads us to a fascinating and, somewhat dark area of engineering.
Bullet design.
Yeah. How do ammunition manufacturers deliberately manipulate this physics to achieve their specific goals?
Well, lead is the primary component of almost all bullets. It is incredibly heavy, which makes it fantastic for carrying kinetic energy.
But lead is also incredibly soft.
Right. It deforms and melts easily under friction, so manufacturers cover it with a metal jacket.
And the sources highlight a massive, clinically vital distinction between two primary types of ammunition you will see.
The full metal jacket, or FMJ, and the jacketed hollow point, or JHP.
As a surgeon, you absolutely must understand the difference, because the clinical presentation of these two bullet types couldn't be more diametrically opposed.
Let's look at the full metal jacket first. An FMJ bullet has its heavy lead core completely encased, or jacketed, by a hard metal, usually a steel or copper alloy.
Completely covered.
Completely. Because of this thick, hard jacket covering the tip, the bullet is explicitly designed to retain its aerodynamic shape upon impact. It actively resists deforming.
Which means it stays narrow and it penetrates deeply.
Very deeply and often completely. FMJ bullets are highly likely to pass entirely through the target and exit the body.
And here is the crucial physical takeaway for that.
Because they exit, they take a massive portion of their kinetic energy with them out the back door rather than transferring it all to the patient's tissues.
They punch a clean hole.
They punch a hole and keep going.
But while that might seem slightly better for the immediate patient on the table, it creates a terrifying tactical problem in the real world.
Overpenetration.
Right. It creates a massive risk overpenetration, meaning collateral damage to innocent bystanders standing behind the target.
Which is exactly why law enforcement and civilian self-defense markets moved away from them.
So what do they use?
They use the jacketed hollow point. These bullets are engineered with their soft lead core exposed at the very tip, or they have a deliberate cavity in airspace hollowed out beneath the jacket at the nose.
They are explicitly designed to expand, to mushroom open the second they strike dense, fluid-filled tissue.
And that expansion is rapid and violent. The hollow tip fills with fluid, hydrostatic pressure builds instantly, and the jacket peels back perfectly like the petals of a flower.
That sounds devastating.
It is. This dramatically, instantly increases the bullet's cross-sectional area. It essentially acts like a parachute deploying at supersonic speed.
Slowing it down instantly.
It decelerates rapidly, and because it decelerates so fast, it dumps almost 100% of its kinetic energy into the surrounding tissue.
So compared to an FMJ, a hollow point causes vastly more collateral tissue damage by direct contact, intense cavitation, and sheer concussive shock waves.
It obliterates the tissue.
Yeah.
And the sources provide an incredible, really chilling visual reference for this.
The X-ray.
Yeah. They describe an anterior-posterior plain X-ray of a patient's left shoulder and upper thorax. In the radiograph, you can clearly see two distinct radiopaque metallic foreign bodies.
One near the shoulder, one in the chest.
Right. One is embedded deep near the humeral head, and the other is resting posteriorly in the upper chest. But what is immediately striking to the radiologist is their shape.
They aren't bullet-shaped anymore.
No, they don't look like oblong pieces of metal at all. They are perfectly star-shaped.
That star shape is the classic, undeniable radiographic signature of a hollow point bullet that is fully expanded on impact.
It peeled back perfectly along its pre-scored stress lines to maximize the tissue damage.
And because they act like parachutes, deforming and dumping their energy so fast, they rarely exit the body, right?
Rarely. You will almost always find them resting in the tissue.
But this brings up a profound historical and legal point. Over a century ago, the international community looked at the devastating shredding effects of these expanding bullets and made a collective decision.
The texts explicitly bring up the Hague Declarations of 1899.
I found this absolutely fascinating. The intersection of clinical trauma surgery and international war law.
It is. In 1899, the world's militaries were transitioning to higher velocity smokeless powder,
Right.
and military surgeons began seeing these catastrophic, untreatable wounds from expanding bullets. So the Hague Declarations explicitly ban the use of military rifle bullets, which expand or flatten easily in the human body.
The text notes, this prohibition was specifically designed to prevent superfluous injury or unnecessary suffering for soldiers on the battlefield.
Because the objective of war, legally and philosophically speaking, is simply to disable the enemy combatant, taking them out of the fight.
It is not to render their death absolutely inevitable through uselessly aggravated, agonizing suffering.
Exactly. Therefore, conventional military forces across the globe are legally bound by this treaty. Standard military rifles are equipped exclusively with non-expanding full metal jacket bullets.
But here is the critical, mind-bending caveat for the civilian trauma surgeon.
This international law does not apply to domestic civilian law enforcement,
Nor does it apply to civilian hunting.
which sets up the unbelievable clinical paradox we mentioned at the start of the deep dive.
Expanding, tissue-shredding bullets are not only perfectly legal for civilian game hunting, they are often legally required by local jurisdictions.
And the rationale makes sense in that specific context.
How so?
A hunter wants to ensure a quick, ethical, humane kill of an animal, dropping it instantly. And secondly, they want to prevent over-penetration.
Right, they don't want the bullet passing entirely through the deer and striking another hunter half a mile away.
Exactly. So they use expanding hollow points or soft points.
But when a human being is accidentally shot with that hunting rifle, perhaps in a hunting accident or tragically in a civilian homicide, the results on your operating table are catastrophic.
Beyond catastrophic.
It means that a civilian hunting accident can, and often does, present with vastly more unrecoverable tissue destruction than a military battlefield wound from an equivalent caliber weapon.
Because the hunting bullet was legally mandated to expand and destroy, well, the military bullet was legally mandated to stay intact.
It's a reality that completely rewrites your expectations in the trauma bay. A military-grade weapon might just punch a clean hole, while a grandfather's hunting rifle is engineered to cause maximum internal cavitation.
It really forces you to check your assumptions at the door.
So we know the legal and physical difference between expanding and non-expanding rounds. But how does that actually play out on a Friday night in a trauma center?
Let's transition from theory to reality.
Yeah, let's look at the weapon profiles you are statistically most likely to see. Let's start with the absolute staple of urban trauma, the handgun.
Handguns are the most common weapon in civilian firearm violence, hands down.
Because they're concealable.
They are lightweight, they're easily concealed, and tactically, they are primarily used in very close-range encounters, usually less than 10 yards.
But because they are small, they have a physical limitation, right?
Right. Because they have to be fired unsupported by the arms and hands, the physical amount of gunpowder in the casing has to be strictly limited to manage the recoil.
If you pack a handgun cartridge with rifle powder,
The recoil would shatter the shooter's wrist or literally blow the gun apart in their hand.
so shorter barrels, less powder. And going back to our physics equation, that translates directly to
The text notes, a standard 9mm handgun bullet travels at about 1,150 feet per second.
compare that to a .45 ACP, which is a much heavier, wider bullet, but it's slower.
Yeah, traveling at about 890 feet per second.
Because of that relatively low velocity, a handgun bullet is much less likely to yaw, violently deform, or fragment inside the tissue compared to a rifle round.
Consequently, the temporary cavitation, the shock wave, is usually slight and clinically insignificant in elastic tissues.
So what's the danger?
The immediate danger to the patient stems primarily from the permanent cavity. You are dealing with a direct crush injury to vital organs or major vasculature in the head, neck, chest, or abdomen.
But the text doesn't just leave us with physics. It gives some highly specific, actionable clinical pearls for managing these low-velocity handgun wounds.
Right, specific surgical algorithms.
For instance, penetrating neck injuries. The text specifically calls out Zone 2 neck injuries. I want to dive into why Zone 2 is so critical.
Zone 2 of the neck is the area between the cricoid cartilage and the angle of the mandible.
It is incredibly dense real estate.
It is. You have the carotid arteries, the jugular veins, the trachea, the esophagus, and the recurrent laryngeal nerve all packed together.
And the text's recommendation.
The text advocates for exploration of Zone 2 injuries if there are hard signs of vascular or aerodigestive tract injury. Even a low-velocity handgun bullet can easily nick a carotid artery.
Leading to an expanding hematoma that rapidly compresses the airway.
Exactly. You have to be ready for an immediate definitive airway.
And for the chest, the text moves away from mandatory operations and leans heavily into selective exploration based on hemorrhage.
Right. If they have a chest tube output of greater than 1,500 milliliters initially or 200 milliliters per hour over consecutive hours, you're going to the OR.
But otherwise, many of these low-velocity chest wounds can be managed non-operatively.
True. But the diaphragm is a major area of concern here. If you have penetrating sites below the nipple line on the chest, you must assume the bullet traversed the diaphragm and entered the abdomen.
And then what?
Abdominal exploration is immediately required if the abdomen is tender, peritonitic, or if you can't visualize the diaphragm well on imaging.
However, in stable, non-tender patients, laparoscopy is an incredibly elegant tool.
It really is. You can directly visualize the diaphragm to rule out occult tears that would later lead to herniation.
Or you can manage low-grade liver penetrations that might result in bile leaks without needing a massive laparotomy incision.
I was actually quite surprised by the recommendations for the right upper quadrant. It seems slightly counterintuitive that you could selectively manage liver penetration non-operatively.
It does feel risky, but the data supports it for low-velocity wounds.
Under what conditions?
If the patient is absolutely hemodynamically stable, a right upper quadrant handgun wound can be selectively evaluated by a high-quality triple-phase CT scan.
Okay.
If the bullet clearly only injured the liver, and there's no evidence of active arterial extravasation, bowel injury, or free air, it can often be safely observed in the ICU.
Because the liver capsule can tamponade the bleeding from a low-velocity permanent cavity?
Exactly.
Yeah.
But we have to remember, while civilian criminals might use cheap FMJ handgun ammo, law enforcement absolutely does not.
No, they overwhelmingly favor jacketed hollow points.
Why?
Because they need to incapacitate a threat instantly without the risk of overpenetration. They cannot risk an FMJ bullet passing through a suspect and striking an innocent bystander in a crowded urban environment.
So even with a handgun, you will absolutely see those star-shaped, fully expanded bullets on X-ray, and the tissue crush injury will be significantly wider.
And we also have to account for Magnum handguns.
Right. They pack more of a punch.
A weapon like a .357 Magnum pushes 1,500 feet per second. They utilize extra powder and slightly longer, reinforced barrels, producing devastating close-range wounds.
Wounds that begin to bridge the clinical gap between a low-velocity handgun and a high-velocity rifle.
Yeah, the temporary cavity starts to become a real factor with Magnums.
Which is the perfect transition to the high-velocity destruction of rifles. If a handgun is a low-velocity crush injury, a hunting rifle is a masterclass in massive energy transfer.
The physics change entirely, and your surgical approach must change with it.
Let's talk about barrel length.
A standard civilian hunting rifle, like a .30-06 or a .308 Winchester, has a massively enhanced barrel length, often 22 to 24 inches, and heavily packed gunpowder.
So what's the muzzle velocity?
A .308 Winchester boasts a muzzle velocity of roughly 300 and 350 feet per second.
Let's do the math on that. 350 feet per second is almost exactly 3 times the speed of our standard 9mm handgun.
And remember the golden equation, velocity is squared.
That means a .308 rifle round doesn't just have 3 times the kinetic energy of a handgun.
It has 9 times the kinetic energy.
9 times the energy. And furthermore, these heavy aerodynamic bullets maintain that energy over incredible distances.
A .30-06 can maintain up to 90% of its kinetic energy even at 100 meters downrange.
So when an expanding hunting bullet strikes an extremity at that speed,
The sheer kinetic energy transfer is apocalyptic. It destroys soft tissue, it obliterates bone into secondary projectiles, and it shreds vasculature through the concussive shockwave alone.
the clinical photographs provided in the text are profoundly sobering.
Hard to look at, really.
There's a specific image of a close-range, negligent discharge from a .30-06 rifle directly to the face.
Yeah.
It resulted in the complete, unrecoverable destruction of the patient's left globe, massive amounts of exposed, devitalized facial muscle, and catastrophic hemorrhagic tissue loss.
It is a devastating, life-altering injury.
For extremity wounds from these high-velocity rifles, the text lays out some incredibly strict surgical recommendations.
Because you cannot trust what you see on the surface.
Not at all.
First, plain radiographs to look for shattered bone fragments are mandatory. But clinically, you must perform operative wound exploration with incredibly aggressive debridement.
The paramount rule here is that even if the overlying skin appears relatively uninjured.
Just a small entry and a slightly larger exit hole.
Exactly. The soft tissue hidden beneath that skin may be irreversibly destroyed by the massive temporary cavity shockwave.
I really want to dig into the mechanism of that tissue death. Why does the muscle look fine initially but die later?
It comes down to microvascular thrombosis. When the temporary cavity balloons outward in a fraction of a millisecond, it violently stretches the muscle fibers and the tiny capillaries feeding them.
The tissue snaps back into place, and under the bright auroral lights, it might look pink and viable.
But the endothelial lining of those capillaries was sheared by the stretch.
Ah, I see.
Over the next 12 to 24 hours, microscopic blood clots form in those shredded capillaries, completely cutting off the blood supply to the muscle.
The tissue slowly suffocates and dies, turning necrotic.
Which means a single surgery is almost never enough. You are hunting for devascularized tissue that hasn't fully declared itself yet.
Serial debridements at daily intervals, bringing the patient back to the OR every 24 to 48 hours, are absolutely necessary to identify and excise all the non-viable tissue as it slowly evolves and turns gray.
You also must remove all pieces of clothing, dirt, or debris that were dragged into the wound tract.
And for evaluating the major vessels, the text highlights the use of intraoperative angiograms.
It is highly recommended. The shockwave can stretch a major artery, like the femoral artery.
It might not sever it.
Right, but it stretches it enough to tear the innermost lining, the tunica intima.
This creates an intimal flap that can act like a one-way valve, suddenly flipping down and occluding blood flow hours after the injury.
An angiogram helps you visualize those occult injuries.
What about abdominal shots from hunting rifles?
For abdominal shots, you are almost always looking at a massive trauma laparotomy and open abdomen techniques.
Given the sheer size of the temporary cavity, the likelihood of multi-organ injury and profound bowel ischemia is immense.
You leave the abdomen open with a temporary vacuum dressing and plan for second-look operations.
Okay, so we've clearly established that civilian hunting rifles cause catastrophic expansive damage, but let's circle back to the military service rifles.
Weapons like the American M4, the M16, or the Russian AK-47 series.
These are firing high-velocity bullets, too. The M4 fires a 5.56 millimeter round at over 3,100 feet per second.
But I have to play devil's advocate here because it feels completely backward.
How so?
Why are trauma surgeons sometimes surprised by how little damage an M4 bullet causes if it happens to pass cleanly through a patient's arm or leg?
It feels like a contradiction of everything we just learned about velocity.
Right. It's a military weapon designed for modern combat.
But to understand it, you have to combine the two rules we've discussed: caliber size and the Hague Declarations.
Right. The requirement for full metal jacket ammunition.
Yes, both the American M4 and the Russian AK-74 deliver a full metal jacket bullet that is actually astonishingly small in diameter.
How small?
A 5.56 millimeter bullet is not much larger in diameter than a tiny .22 caliber small game round used for hunting squirrels.
Wow.
Its lethality comes purely from its speed. But because it is an FMJ, it is explicitly designed not to expand.
So let's walk through the exact physical scenario.
Yeah.
If that 5.56 round strikes a patient's bicep and it doesn't happen to strike the humerus bone,
And if the tissue path is short enough, a bicep is only a few inches thick, that the bullet simply exits the back of the arm before it has a chance to lose its gyroscopic stability and yaw.
what does it do?
It essentially behaves like a supersonic needle. It passes cleanly through, it creates a small, narrow, permanent cavity, and it takes almost all of its tremendous kinetic energy completely out the exit wound.
If it doesn't yaw, it doesn't dump the energy.
Exactly. So the surrounding tissue damage, the temporary cavity, won't be nearly as dramatic or destructive as a deformable, larger caliber civilian hunting bullet that dumped all its energy into the arm.
It contradicts the movies, but it perfectly follows the laws of physics.
However, there is a massive clinical caveat to this.
What if it hits a bone?
If that same 5.56 millimeter bullet does strike a bone, it shatters the bone into secondary projectiles and instantly destabilizes the bullet, causing it to yaw and tumble.
Or if it hits a thicker body part?
Right. If it travels through a thicker part of the body, like the torso or the thigh, where it has enough physical distance to lose its stability and yaw, the temporary cavity will be absolutely massive and devastating.
Which is why the texts stress over and over that the decision to debride additional tissue must be at your discretion as the operating surgeon looking at the living tissue.
You cannot base your surgical plan solely on the type of weapon or ammunition reported by EMS on the radio.
No, you have to meticulously assess the tissue viability in front of you.
Because the trajectory inside the body is entirely unpredictable once it hits bone or begins to yaw.
With military rifles, abdominal wounds often feature multiple areas of bowel injury and solid organ disruption from fragmentation or violent tumbling.
And for thoracic penetrations, if the patient is stable and you are attempting non-operative therapy, you need continuous ultrasonic visualization of the pericardial space to rule out tamponade.
And esophageal contrast radiography to ensure the shockwave didn't tear the esophagus?
And for those extremity wounds, the text gives a very specific hard metric. An angiogram is strictly indicated if the ankle brachial index, the ABI, is 0.9 or less.
That is a vital, non-negotiable clinical pearl. If the ADI is 0.9 or less in a high-velocity extremity wound, it demands an angiogram.
You are looking for that exact occult vascular injury we discussed. The intimal flap or microvascular thrombosis caused by the temporary cavitation, even if the vessel looks externally intact.
And we should explicitly note, while the M4 is a military platform, its civilian semi-automatic equivalent, the AR-15 fires the exact same calibers, like the .223 or 5.56 millimeter.
The physics of the wound ballistics, the velocity, and the tissue destruction are absolutely identical.
Which brings us to a whole new level of ballistic complexity. We spent this entire time covering standard, single projectiles, one bullet, one path.
But how does the math change when you encounter weapons that don't fire a single bullet, or weapons that rely on explosive blasts?
Or, conversely, what happens with weapons explicitly designed not to be lethal?
Let's tackle shotguns first, because they operate on a completely different physical premise than rifles. They are incredibly common, and the wounds are uniquely horrific.
Shotguns are designed to fire a cluster of spherical pellets rather than a single aerodynamic bullet.
The barrel has no rifling. It's a smooth bore. The shell sizes are measured in gauges: 10, 12, 20 gauge, or .410.
And the actual payload of lead inside that plastic shell can be drastically different depending on what the shooter loaded.
You have birdshot, which consists of hundreds of tiny lead or steel pellets.
Like how many?
A standard number 4 birdshot shell, for example, holds between 130 and 190 individual pellets, each less than .13 inches in diameter.
Then you have buckshot, designed for larger game.
Double-aught buckshot holds just 8 or 9 large lead pellets, each about a third of an inch in diameter, roughly the size of a 9mm bullet.
Because they are spheres, they are aerodynamically terrible.
They have a relatively low muzzle velocity compared to rifles, and because they are round, they lose their speed incredibly rapidly due to air resistance.
The range is an issue.
A shotgun-firing birdshot is generally completely ineffective against a human target at distances greater than 10 or 15 yards. The pellets spread out and lose their kinetic energy.
But the clinical reality changes drastically at close range. What happens at less than 4 feet?
At point blank or close range, the blast is devastating. The entire cluster of pellets hasn't had time to spread out yet. It strikes the tissue as a single, massive, heavy mass of lead.
Shotgun wounds at close range are extremely morbid, often requiring multidisciplinary management.
Yeah, involving trauma, orthopedics, plastics, and vascular teams, and several complex operations.
As the pellets enter, they act like billiard balls, striking each other and spreading radially in every direction through the tissue, striking multiple different organs simultaneously.
And here is a terrifying clinical reality the text highlights: arterial embolization.
Tell us about that.
Because these pellets are small and spherical, they can easily punch into the lumen of a major blood vessel, lose their momentum, and literally be pumped through the patient's circulatory system.
It is a phenomenal complication to anticipate.
There is a specific fluoroscopy image in the text showing a case where shotgun birdshot entered the patient's superficial femoral artery in the thigh.
And where did they go?
The pellets embolized all the way down into the distal tiny arteries of the patient's lower leg and foot. On the scan, you can see these tiny radiopaque spheres scattered deep down the vasculature, cutting off blood supply far from the actual wound site.
The pellets can embolize peripherally, like in that leg, or if they enter a vein, they can embolize centrally, traveling straight to the lungs or lodging in the right ventricle of the heart.
But here's where it gets really complicated for the surgeon exploring a close-range shotgun wound. It's not just the metal pellets you have to worry about finding.
Right. When a shotgun fires, it doesn't just expel the lead pellets. Inside the shell, the pellets are held in a plastic cup, or wadding, that separates them from the gunpowder.
In close-range blasts, that plastic wadding is fired directly into the wound bed along with the lead.
Furthermore, the immense chaotic temporary cavity of a close-range blast acts almost like a vacuum as it collapses,
sucking pieces of the patient's clothing, skin bacteria, and environmental debris deep into the wound tract.
You have to actively hunt for and surgically remove that hidden plastic wadding and debris, or the patient will develop a massive, deeply seated infection.
And what about the actual chest and abdominal cavities?
Thoracic wounds from a close-range shotgun blast are gruesome. They may result in a massive, gaping loss of the chest wall itself.
The surgeon is sometimes required to perform emergent muscular flaps or even diaphragm transposition just to physically cover the open defect in the chest cavity.
Abdominal shotgun wounds absolutely mandate serial operations. The massive, widespread blast effect causes diffuse bowel ischemia that might not be at all visible on your initial exploration.
The bowel might look pink on day 1, but die on day 2.
This means the open abdomen technique with a temporary vacuum dressing is often required until the bowel viability declares itself.
Now let's scale up that blast effect exponentially. Improvised explosive devices, or IEDs, and conventional landmines.
The text notes these are highly variable, ranging from small, crude, homemade explosives packed with nails to complex, military-grade shaped charges.
The detonation of an IED is a multi-system mechanism of injury. First, the explosion hurls primary and secondary fragments pieces of the bomb casing: nails, rocks, glass showering the victim's extremities, perineum, torso, and face.
But it's the primary blast wave itself, the supersonic wall of overpressure, that adds a layer of insidious, invisible injury.
Just like the shotgun, the blast effect from an IED violently compresses gas-filled organs, resulting in catastrophic bowel ischemia, pulmonary hemorrhage, and tissue death that is not immediately evident at the initial, frantic laparotomy.
The military standard of care here, which translates perfectly to civilian mass casualty events, is absolute damage control surgery.
You aren't doing definitive, beautiful, complex bowel anastomoses or vascular repairs on day one.
You are stopping the catastrophic bleeding, you are controlling the gross bowel contamination by stapling off injured segments, you are using temporary external fixators for bone stability, and you are planning for repeated aggressive debridements of devascularized tissue.
In austere settings, vascular injuries are simply temporized with plastic shunts to keep the limb alive.
But let's look at a very specific mechanism: conventional, foot-triggered anti-personnel landmines.
The text describes a fascinating and incredibly deceptive anatomical phenomenon called the umbrella effect.
I was absolutely mesmerized by the biomechanics of the umbrella effect. Walk us through exactly what happens to the lower leg.
When a patient steps on a conventional landmine, the immense explosive force travels directly upward from the heel or the midfoot.
But the blast follows the path of least resistance.
The deep fascial compartments of the lower leg are incredibly tough. The blast wave tends to spare the flexible skin and subcutaneous tissue of the lower leg, acting almost like a protective sheath.
While the force travels violently up the fascial planes, entirely destroying and obliterating the underlying muscle, the tibia and fibula, and the neurovascular bundles.
So to a junior surgeon, the outside of the leg might look relatively intact.
The skin might just have a few small lacerations, hiding absolute pulp destruction beneath.
Exactly. And the skin hides significant deep contamination. The immense upward pressure strips the periosteum off the bone and drives dirt, boot material, and bone fragments deep into the popliteal fossa behind the knee.
The critical clinical pearl here is that you must perform wide, aggressive fasciotomies and debridement.
Because if you leave that devitalized tissue inside the intact skin, anaerobic infection will rapidly track along the popliteal vessels and the neural sheaths all the way up into the deep thigh, leading to overwhelming sepsis and high amputations.
Okay, we've talked about weapons explicitly designed to kill or maim. What about technologies designed to protect, or weapons designed to be non-lethal?
This introduces a whole new set of physics that trauma surgeons are seeing more frequently.
Let's start with body armor. Armored plates and Kevlar vests are rigorously rated by the National Institute of Justice, the NIJ.
For instance, level Thigh A soft armor protects against high-velocity handgun rounds like the .44 Magnum, while rigid level 4E ceramic plates are designed to stop .3 Atoncho caliber armor-piercing rifle rounds.
But this raises a fundamental physics question. If I shoot a patient wearing a level 4V plate with a high-velocity rifle, and the bullet shatters against the plate and doesn't penetrate the skin,
Right.
the kinetic energy didn't just magically disappear. Where does it go?
It doesn't disappear, it disperses.
Yeah.
The vest catches the bullet, preventing the permanent cavity, but the immense blunt force, the kinetic energy, is dissipated entirely into the vest and transferred directly onto the wearer's chest wall.
It is essentially equivalent to being struck by a sledgehammer.
The text emphasized that high-fidelity models show significant damaging pressure waves traveling through the body after a vest impact.
Meaning you can have massive pulmonary contusions, severely displaced rib fractures, and concussive injury to hollow and solid organs, despite the complete and total lack of a penetrating entry or exit wound.
You have to evaluate that patient for severe, high-energy, blunt force trauma, almost as if they were in a high-speed motor vehicle collision.
And we see a very similar deceptive mechanism of injury with non-lethal or less lethal ammunition used by law enforcement for riot control things like rubber bullets, plastic baton rounds, or beanbag rounds fired from a standard 12-gauge shotgun.
The concept behind a beanbag round is just a small cloth sack filled with lead birdshot.
The idea is that it flies through the air, and upon impact, the bag flattens out, diffusing the kinetic impact over a much larger surface area so it doesn't break the skin.
Theoretically, yes, but the injury is highly dependent on the velocity, the distance traveled, and the specific anatomical site of impact.
At close ranges, the concentrated blunt force acts just like the behind armor trauma.
It causes severe, life-threatening abdominal injuries, ruptured spleens, shattered livers, perforated bowel, and despite their non-lethal design, penetration of the skin absolutely does occur at close range.
Furthermore, if a rubber bullet or beanbag round strikes the rigid, relatively fragile bones of the face or the cranium, it can easily be fatal, causing depressed skull fractures and traumatic brain injury.
You must perform a thorough head-to-toe evaluation with a very low threshold for CT imaging to rule out deep, life-threatening injuries.
This brings us to a really fascinating foundational part of our deep dive: How do we actually know all of this?
When we talk about the exact shape of a temporary cavity or the exact rate of energy transfer of an expanding bullet, how are we so sure?
We certainly aren't gaining this precise data from chaotic emergency room reports or post-op dictations.
No, clinical reports are far too messy with too many unknown variables. This is where the rigorous laboratory work of the ICRC is so utterly vital to our understanding.
They use internationally validated, strictly controlled soft tissue simulants to study experimental wound ballistics in a highly reproducible laboratory environment.
And reading through their methodology, they use two primary materials to simulate human flesh: glycerin soap and gelatin.
Why use two completely different materials to study the same bullet?
Because they capture two entirely different moments in time during the ballistic event. Glycerin soap is engineered to have the exact same density as human soft tissue, but it lacks any elasticity. It is completely plastic.
So when you fire a high-velocity bullet into a massive block of glycerin soap,
The soap is crushed and pushed violently outward by the temporary cavity, but it doesn't snap back. It permanently freezes the temporary cavity at its absolute maximum expansion.
so the researchers can literally take a wire cutter, slice the soap block exactly in half down the wound track, and look at the entire perfectly preserved wound profile.
You can see the exact centimeter where the bullet lost stability and yawed, and you can measure the physical volume of the displaced soap to calculate exactly how much kinetic energy was deposited for every single centimeter of the wound track.
It is a perfect frozen mold of the violence.
Yes, it provides flawless measurements of energy transfer. But to see the actual physics in motion, to see how human muscle reacts, they use 10% or 20% gelatin blocks.
Gelatin has an inherent elasticity that very closely resembles living mammalian muscle tissue,
And crucially, it is completely transparent.
which allows them to aim ultra-high-speed sign cameras at the block and literally watch the temporary cavity violently expand, collapse, and pulsate in real time as the bullet flies through.
They even take it a step further. They embed rigid polyurethane tubes inside the transparent gelatin to simulate human long bones, complete with a thin layer of latex wrapped around them to simulate the tough periosteum.
It's an incredible high-fidelity setup.
And this pristine laboratory setting allows them to isolate specific variables that are impossible to isolate in combat.
For example, they can study the fragmentation from explosive weapons like IEDs by firing differently shaped steel or rubber spheres into the soap blocks at specific velocities.
The text makes a really profound, deeply counterintuitive point about those explosive fragments.
If you picture an IED fragment, you picture a jagged, twisted, razor-sharp piece of steel shrapnel.
But the ICRC researchers found that the actual shape of the fragment makes almost zero difference to the shape of the wound track it creates.
It is entirely true, and it comes back to fluid dynamics. Whether the projectile is a highly irregular, jagged, asymmetrical shard of metal or a perfectly smooth, machined steel sphere, the resulting permanent and temporary wound track in the tissue is almost always perfectly circular in cross-section.
How is that physically possible? A jagged piece of metal should cut a jagged hole.
Because an irregular asymmetric fragment flying through the air will always naturally tumble. As it meets the intense resistance of dense tissue, it will invariably present its widest, most blunt surface area forward.
As it pushes through at high velocity, the tissue is accelerated evenly and radially away from the most forward point of that blunt surface area.
The text uses a truly beautiful, elegant analogy to explain this. Whatever the shape or size of a stone you throw into a still pond, whether it's a flat skipping stone or a jagged rock, the resulting ripples expanding outward in the water always form a perfect concentric circle.
The dense human tissue reacts the exact same way to the immense kinetic energy of a fragment.
Which is why a perfectly smooth steel sphere is actually a flawless laboratory surrogate for a chaotic bomb fragment.
Okay, let's use our last segment to tackle the biggest, most pervasive myth in all of gunshot wound management.
It's the question every single patient and every single patient's terrified family asks the surgeon the moment they wake up in the recovery room. Did you get the bullet out?
It is the single most persistent myth in ballistic trauma, perpetuated by Hollywood and centuries of outdated medical dogma.
Patients genuinely believe the bullet itself is a ticking time bomb, a toxic piece of lead that will inevitably cause overwhelming infection or heavy metal poisoning if left inside their body.
But the modern surgical texts, backed by decades of data, are unambiguous. Routine bullet removal is generally completely unnecessary, and it should ideally never be the sole indication for taking a patient to the operating room.
I can hear the patient's argument now, though. Isn't a piece of metal covered in unburnt gunpowder and lead residue inherently dirty? How could you just leave it next to my spine?
It is absolutely non-sterile, but the physics of the firing process mitigate the risk. The intense friction and searing heat of the bullet traveling down the barrel sterilizes the surface to some degree.
When you combine that with the robust physiological immune response of healthy human tissue encapsulating the foreign body, the actual clinical risk of an abscess or infection directly stemming from a retained, simple bullet is exceptionally low, less than 2% in most studies.
Because the risk is so statistically low, you don't even need to prescribe prophylactic intravenous antibiotics for a simple retained bullet, provided you've performed basic thorough wound irrigation in the ER within 6 hours of the injury.
So if the bullet itself isn't the primary driver of infection, what is the biggest risk factor?
Delay in definitive treatment of the crushed tissue, and massive tissue devascularization. If you irrigate the wound early, remove gross debris like clothing, and address the patient's tetanus vaccination status, leaving the bullet exactly where it rests is the gold standard of care.
Chasing a bullet through healthy, uninjured tissue causes far more iatrogenic, surgeon-induced damage than simply leaving it alone.
As the authors poignantly note, many a well-intentioned surgeon has spent hours blindly searching subcutaneous tissue in vain, destroying healthy muscle and nerves, desperately looking for a foreign body that seemed to be just beneath the skin on a two-dimensional X-ray.
Okay, but this is medicine. There are always exceptions. When is a trauma surgeon absolutely medically required to remove a bullet?
There are a few very specific, highly evidence-based indications for mandatory bullet extraction.
The first is intravascular embolization.
If a bullet or a shotgun pellet has entered the vascular tree and is resting inside a major artery, a vein, or lodged inside a cardiac chamber, it absolutely must be extracted.
If left alone, it will inevitably cause catastrophic downstream ischemia, profound valvular dysfunction, or it will act as a nidus for massive fatal thrombosis.
What about the risk of lead poisoning? That's the other major fear patients articulate. They worry the lead will leach into their blood and destroy their brain.
True systemic lead poisoning plumbism from a retained bullet in soft tissue or muscle is actually exceptionally rare. Lead simply does not readily dissolve in the normal pH environment of human soft tissue.
However, there are two specific, unique anatomical environments where lead will rapidly dissolve. The first is synovial fluid.
If a bullet or a pellet is resting inside a joint capsule, say the knee or the hip in direct continuous contact with synovial fluid, the lead will absolutely dissolve over time, enter the bloodstream, and cause severe systemic lead toxicity.
And by extrapolation, the text notes the exact same chemical principle is true for cerebrospinal fluid.
So bullets resting freely in joint spaces or floating in the spinal canal carry a genuine documented risk of lead poisoning and must be strongly considered for removal.
Exactly. The fluid acts as a solvent. The final major clinical exception is osteomyelitis.
Bullets that pass through a heavily contaminated environment. Specifically, bullets that perforate the colon and drag feces with them, and subsequently lodge deeply into the marrow of a bone, are at a very high risk of causing severe, intractable, limb-threatening bone infections.
At the author's trauma center, they strongly favor surgically removing those specific projectiles, provided they are surgically accessible without causing further catastrophic damage.
And if they aren't accessible, say it's lodged deep in the pelvis.
The alternative is incredibly aggressive, copious irrigation of the bullet tract, attempting to wash out the gross contamination, followed by a very heavy, prolonged course of broad-spectrum high-V antibiotics.
So to summarize the rule, unless the bullet is in a blood vessel, a joint space, the spinal fluid, or acting as a plug in a contaminated bone, you leave it alone.
As a trauma surgeon, you are treating the catastrophic anatomical damage the bullet caused on its violent way in. You are not treating the inert piece of metal resting at the end of the track.
So, synthesizing everything we've covered today, if you are that trauma surgeon standing at the foot of the bed in the trauma bay at 2 a.m., looking at a patient who just rolled in with a high-velocity gunshot wound, what is the ultimate application of all this physics, international law, and clinical data?
It means you cannot simply fall back on treating the visible hole. You must radically expand your diagnostic mindset to encompass the entire chaotic ballistic event.
You need to understand the weapon. Was it a low-velocity urban handgun or a high-velocity civilian hunting rifle?
You need to understand the ammunition. Was it an FMJ round that likely passed cleanly through like a needle, or was it a hollow point that aggressively expanded, dumped a massive amount of kinetic energy, and yawed violently inside the tissue?
Because that knowledge dictates your surgical plan. You are actively anticipating the hidden, devastating temporary cavity.
You're watching the fluoroscopy for the risk of arterial embolization from shotgun pellets.
You're explicitly planning for serial debridements in the OR over the next 3 days because you fundamentally understand that the kinetic shock wave irreversibly destroy the microvasculature of muscle tissue that currently looks perfectly pink and healthy under your surgical lights.
Exactly. You're treating the violent, chaotic transfer of kinetic energy. The physics dictate the physiology. If you ignore the physics, you will miss the occult injuries, and the patient will suffer for it.
Which leaves us with a final, highly provocative thought to mull over as we close this deep dive. We've seen how historical military conventions like the Hague Declarations of 1899 deliberately banned bullet expansion to reduce the unnecessary suffering of soldiers on the battlefield.
Meanwhile, civilian hunting ammunition is legally mandated to optimize that exact same expansion.
But today, the lines are blurring. Civilian, law enforcement, and military weapons platforms are increasingly, undeniably overlapping.
The civilian AR-15 fires the exact same caliber at the exact same velocity as the military M4. Domestic law enforcement frequently utilizes the aggressively expanding hollow point rounds that are explicitly banned in international warfare.
And as bullet technology continually evolves specifically to defeat modern synthetic body armor, transferring unimaginable concussive pressure waves directly into the human torso without even breaking the skin. Our established surgical protocols, our damage control strategies, and our urban trauma systems truly keeping pace with the physics of tomorrow's projectiles.
It is an ongoing, terrifying race between ballistic engineering and human surgical resilience. And the trauma surgeon is the one standing squarely at the finish line, tasked with putting the pieces back together.
So the next time you look at that X-ray in the trauma bay, and you see that murky, fragmented, chaotic landscape instead of a clean, jagged white line of a simple fracture, remember that you aren't just looking at broken anatomy. You're looking at a frozen moment of kinetic violence. Treat the energy, not just the metal.